Management of women with endometriosis. Introduction. Endometriosis is defined as the presence of endometrial-like tissue outside the uterus, which induces a chronic inflammatory reaction. While some women with endometriosis can experience painful symptoms and/or infertility, others have no symptoms at all. The exact prevalence of endometriosis is unknown, but estimates range from 2 to 10% of women of reproductive age to 50% of infertile women. Diagnosis. Which symptoms are associated with or predictive of the diagnosis of endometriosis? Based on the included studies and expert opinion, the Guideline Development Group decided on the following good practice points. The Guideline Development Group, or GDG, recommends that clinicians should consider the diagnosis of endometriosis in the presence of gynecological symptoms such as dysmenorrhea, non-cyclical pelvic pain, deep dyspareunia, heavy menstrual bleeding, infertility, fatigue, postcoital bleeding, and/or previous diagnosis of ovarian cyst, irritable bowel syndrome, or pelvic inflammatory disease. In women of reproductive age with non-gynecological cyclical symptoms, dyschezia, dysuria, hematuria and rectal bleeding, and shoulder pain. What findings during clinical examination are predictive for the presence and localization of pelvic endometriosis? The Guideline Development Group recommends that clinicians should perform clinical examination in all women suspected of endometriosis, although vaginal examination may be inappropriate for adolescents and/or women without previous sexual intercourse. In such cases, rectal examination can be helpful for the diagnosis of endometriosis. Clinicians may consider the diagnosis of deep endometriosis in women with painful induration and/or nodules of the rectovaginal wall found during clinical examination or visible vaginal nodules in the posterior vaginal fornix. Clinicians may consider the diagnosis of ovarian endometrioma in women with adnexal masses detected during clinical examination. Clinicians may consider the diagnosis of endometriosis in women suspected of the disease even if the clinical examination is normal. Can the diagnosis of endometriosis be made by application of a specific medical technologies? The diagnosis of endometriosis is suspected based on the history, the symptoms and signs, is corroborated by physical examination and imaging techniques, and is finally proven by histological examination of specimens collected during laparoscopy. The combination of laparoscopy and the histological verification of endometrial glands and/or stroma is considered to be the gold standard for the diagnosis of the disease. The Guideline Development Group recommends that clinicians perform a laparoscopy to diagnose endometriosis, confirm a positive laparoscopy by histology. The Guideline Development Group recommends that clinicians obtain tissue for histology in women undergoing surgery for ovarian endometrioma and/or deep infiltrating disease to exclude rare instances of malignancy. Ultrasound. In women with symptoms and signs of rectal endometriosis, transvaginal sonography or TVS is useful for identifying or ruling out rectal endometriosis. Transvaginal sonography for the diagnosis of rectal endometriosis is highly operator dependent and experience is often lacking. Hence, transvaginal sonography is not recommended for diagnosis of rectal endometriosis unless it is performed by clinicians highly experienced in transvaginal sonography or TVS. Clinicians are recommended to perform TVS to diagnose or to exclude an ovarian endometrioma. The Guideline Development Group recommends that clinicians base the diagnosis of ovarian endometrioma in premenopausal women on the following ultrasound characteristics: ground glass echogenicity and 1 to 4 compartments, and no papillary structures with detectable blood flow. Magnetic resonance imaging. Clinicians should be aware that the usefulness of magnetic resonance imaging or MRI to diagnose peritoneal endometriosis is not well established. Biomarkers. Clinicians are recommended not to use biomarkers in endometrial tissue, menstrual or uterine fluids, and/or immunological biomarkers, including CA125, in plasma, urine, or serum to diagnose endometriosis. The Guideline Development Group recommends that clinicians should assess ureter, bladder, and bowel involvement by additional imaging if there is a suspicion based on history or physical examination of deep endometriosis in preparation for further management. Treatment of endometriosis-associated pain. Empirical treatment of pain. Many women suffering from pelvic pain, while there is a high suspicion of endometriosis, use analgesics and hormonal medication without a prior definitive diagnosis of the disease by laparoscopy. This is partially due to the invasiveness of the laparoscopic procedure. This empirical treatment is especially common in adolescents with pelvic pain and dysmenorrhea. However, before starting empirical treatment, other causes of pelvic pain symptoms should be considered and excluded where possible. The Guideline Development Group recommends clinicians to consult women with symptoms presumed to be due to endometriosis thoroughly and to empirically treat them with adequate analgesia, combined hormonal contraceptives, or progestogens. Are hormonal therapies effective for painful symptoms associated with endometriosis? Currently, hormonal contraceptives, progestogens, and antiprogestogens, gonadotrophin-releasing hormone agonist and antagonist, and aromatase inhibitors are in clinical use. Clinicians are recommended to prescribe hormonal treatment, hormonal contraceptives level B, progestogens level A, antiprogestogens level A, or gonadotrophin-releasing hormone agonist level A as it reduces endometriosis-associated pain. Take patient preferences, side effects, efficacy, costs, and availability into consideration when choosing hormonal treatment for endometriosis-associated pain. Hormonal contraceptives. Hormonal contraceptives were shown to be effective in treating pain in women with endometriosis. Clinicians can consider prescribing a combined hormonal contraceptive as it reduces endometriosis-associated dyspareunia, dysmenorrhea, and non-menstrual pain. Clinicians may consider the continuous use of combined oral contraceptive pill in women suffering from endometriosis-associated dysmenorrhea. Clinicians may consider the use of a vaginal contraceptive ring or a transdermal such as estrogen and progestin patch to reduce endometriosis-associated dysmenorrhea, dyspareunia, and chronic pelvic pain. Progestogens and antiprogestogens. Clinicians are recommended to use progestogens, medroxyprogesterone acetate, oral or depot, Dynogest, cyprotherone acetate, norethisternone acetate, or danazol, or antiprogestogens, gestrinone, as one of the options to reduce endometriosis-associated pain. The Guideline Development Group recommends that clinicians take the different side effect profiles of progestogens and antiprogestogens into account when describing these drugs, especially irreversible side effects such as thrombosis and androgenic side effects. Clinicians can consider prescribing a levonorgestrel-releasing intrauterine system as one of the options to reduce endometriosis-associated pain. Gonadotrophin-releasing hormone agonist. Clinicians are recommended to use gonadotrophin-releasing hormone agonists such as nafarelin, leuproride, buserelin, goserelin, or triptorelin as one of the options for reducing endometriosis-associated pain. Clinicians are recommended to prescribe hormonal add-back therapy to coincide with the start of gonadotrophin-releasing hormone agonist therapy and to prevent bone loss and hypoestrogenic symptoms during treatment. This is not known to reduce the effect of treatment on pain relief. Give careful consideration to the use of gonadotrophin-releasing hormone agonists in young women and adolescents, since these women may not have reached maximum bone density. Aromatase inhibitors. In women with pain from rectovaginal endometriosis, refractory to other medical or surgical treatment, clinicians can consider prescribing aromatase inhibitors in combination with oral contraceptive pills, progestogens, or gonadotrophin-releasing hormone analogs as they reduce endometriosis-associated pain. Due to the severe side effects, aromatase inhibitors should only be prescribed to women after all other options for medical or surgical treatment are exhausted. Are analgesics effective for symptomatic relief of pain associated with endometriosis? The Guideline Development Group recommends that clinicians should consider NSAIDs or other analgesics to reduce endometriosis-associated pain. When prescribing NSAIDs, clinicians should discuss the side effects associated with frequent use, including inhibition of ovulation, risk of gastric ulceration, and cardiovascular disease with the patient. Is surgery effective for painful symptoms associated with endometriosis? When endometriosis is identified at laparoscopy, clinicians are recommended to surgically treat endometriosis as this is effective for reducing endometriosis-associated pain, that is, see and treat. Laparoscopic surgery is usually associated with less pain, shorter hospital stay, and quicker recovery, as well as better cosmetic outcome. Hence, it is usually preferred to open surgery. Clinicians may consider both ablation and excision of peritoneal endometriosis to reduce endometriosis-associated pain. Excision of lesions could be preferential with regard to the possibility of retrieving samples for histology. In women with ovarian endometrioma, clinicians should perform cystectomy instead of drainage and coagulation, as cystectomy reduces endometriosis-associated pain. Consider performing cystectomy rather than carbon dioxide laser vaporization in women with ovarian endometrioma because of a lower recurrence rate of the endometrioma. Clinicians can consider performing surgical removal of deep endometriosis as it reduces endometriosis-associated pain and improves quality of life. The Guideline Development Group recommends that clinicians refer women with suspected or diagnosed deep endometriosis to a center of expertise that offers all available treatments in a multidisciplinary context. Hysterectomy. The Guideline Development Group recommends that clinicians consider hysterectomy with removal of the ovaries and all visible endometriosis lesions in women who have completed their family and failed to respond to more conservative treatments. Women should be informed that hysterectomy will not necessarily cure the symptoms or the disease. Surgical interruption of pelvic nerve pathways. Clinicians should not perform laparoscopic uterosacral nerve ablation, or LUNA, as an additional procedure to conservative surgery to reduce endometriosis-associated pain. Clinicians should be aware that presacral neurectomy, or PSN, is effective as an additional procedure to conservative surgery to reduce endometriosis-associated midline pain, but it requires high degree of skill and is a potentially hazardous procedure. Adhesion prevention after endometriosis surgery. Clinicians can use oxidized regenerated cellulose during operative laparoscopy for endometriosis as it prevents adhesion formation. It is not reasonable for clinicians to use icodextrin after operative laparoscopy for endometriosis to prevent adhesion formation as no benefit has been shown. The Guideline Development Group recommends that clinicians should be aware that other anti-adhesion agents, polytetrafluoroethylene surgical membrane, hyaluronic acid products, have been studied and proven effective for adhesion prevention in the context of pelvic surgery, although not specifically in women with endometriosis. Are preoperative hormonal therapies effective for treatment of pain? Clinicians should not prescribe preoperative hormonal treatment to improve the outcome of surgery for pain in women with endometriosis. The Guideline Development Group recommends that clinicians clearly distinguish adjunctive short-term, equivalent to less than 6 months, of hormonal treatment after surgery from long-term, greater than 6 months hormonal treatment. The latter is aimed at secondary prevention. The Guideline Development Group concluded that there is no proven benefit of post-operative hormonal therapy within 6 months after surgery, if this treatment is prescribed with the sole aim of improving the outcome of surgery, as contraception or secondary prevention. Clinicians should not prescribe adjunctive hormonal treatment in women with endometriosis for endometriosis-associated pain after surgery, as it does not improve the outcome of surgery for pain. Is there a role for secondary prevention of disease and painful symptoms in women treated for endometriosis? Secondary prevention is defined as interventions to prevent the recurrence of pain symptoms or the recurrence of disease in the long term, defined as more than 6 months after surgery. In women operated on for an endometrioma greater than or equal to 3 centimeters, clinicians should perform ovarian cystectomy instead of drainage and electrocoagulation for the secondary prevention of endometriosis-associated dysmenorrhea, dyspareunia, and non-menstrual pelvic pain. After cystectomy for ovarian endometrioma in women not immediately seeking conception, clinicians are recommended to prescribe combined hormonal contraceptives for the secondary prevention of endometrioma. In women operated on for endometriosis, clinicians are recommended to prescribe post-operative use of a levonorgestrel-releasing intrauterine system or a combined hormonal contraceptive for at least 18 to 24 months as one of the options for the secondary prevention of endometriosis-associated dysmenorrhea, but not for non-menstrual pelvic pain or dyspareunia. Extragenital endometriosis. Endometriosis has been found in almost every tissue type in the body. Symptoms depend on the site of the disease. Cyclicity of symptoms is usually present, at least in early stages, and may be the only clue that leads to the diagnosis of endometriosis. Diagnosis is usually made by histological confirmation, which is important to exclude other pathology, particularly malignancy. Additional imaging and endoscopic investigations specific to the location may also be used. Extragenital endometriosis can affect different tissues and body parts outside the genital tract. Pain is the most common presenting symptom, although a wide range of symptoms can manifest. Treatment will also depend on the site. If complete excision is possible, this is the treatment of choice. When this is not possible, long-term medical treatment is necessary. Clinicians may consider surgical removal of symptomatic extragenital endometriosis when possible to relieve symptoms. When surgical treatment is difficult or impossible, clinicians may consider medical treatment of extragenital endometriosis to relieve symptoms. What other pain management strategies are effective for symptomatic relief of pain associated with endometriosis? The Guideline Development Group has retrieved and evaluated existing evidence on complementary and alternative treatment options for pain in women with endometriosis and concluded that the effectiveness of high-frequency transcutaneous electrical nerve stimulation, dietary supplements, acupuncture, and traditional Chinese medicine are not well established for pain management in endometriosis. Treatment of endometriosis associated infertility. Are hormonal therapies effective for infertility associated with endometriosis? Suppression of ovarian function by means of hormonal contraceptives, progestogens, gonadotrophin-releasing hormone analogs or danazol to improve fertility in minimal to mild endometriosis is not effective and should not be offered for this indication alone. In infertile women with endometriosis, clinicians should not prescribe hormonal treatment for suppression of ovarian function to improve fertility. Is surgery effective for infertility associated with endometriosis? In women with minimal to mild endometriosis, the evidence summarized in a Cochrane review shows that operative laparoscopy is more effective than diagnostic laparoscopy in improving ongoing pregnancy rates. In infertile women with AFS or ASRM stage 1 or 2 endometriosis, clinicians should perform operative laparoscopy, excision or ablation of the endometriosis lesions, including adhesiolysis, rather than performing diagnostic laparoscopy only to increase ongoing pregnancy rates. In infertile women with AFS or ASRM stage 1 or 2 endometriosis, clinicians may consider carbon dioxide laser vaporization of endometriosis instead of monopolar electrocoagulation, since laser vaporization is associated with higher cumulative spontaneous pregnancy rates. In infertile women with ovarian endometrioma undergoing surgery, Clinicians should perform excision of the endometrioma capsule instead of drainage and electrocoagulation of the endometrioma wall to increase spontaneous pregnancy rates. The Guideline Development Group recommends that clinicians counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of the ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. In women with moderate to severe endometriosis, there are no controlled studies comparing reproductive outcome after surgery and after expectant management. In infertile women with AFS or ASRM stage 3 or 4 endometriosis, clinicians can consider operative laparoscopy instead of expectant management to increase spontaneous pregnancy rates. Are hormonal therapies effective as an adjunct to surgical therapy for treatment of infertility? In infertile women with endometriosis, the Guideline Development Group recommends clinicians not to prescribe adjunctive hormonal treatment before surgery to improve spontaneous pregnancy rates, as suitable evidence is lacking. It is important to realize that clinicians should not withhold hormonal treatment for pain from symptomatic women in the waiting period before undergoing surgery or medically assisted reproduction or MAR. In infertile women with endometriosis, clinicians should not prescribe adjunctive hormonal treatment after surgery to improve spontaneous pregnancy rates. In infertile women with AFS, ASRM stage 1 or 2 endometriosis, clinicians may consider performing intrauterine insemination or IUI with controlled ovarian stimulation within 6 months after surgical treatment, since pregnancy rates are similar to those achieved in unexplained infertility. Assisted reproduction technology or ART. The Guideline Development Group recommends the use of ART for infertility associated with endometriosis, especially if tubal function is compromised or if there is male factor infertility and or other treatments have failed. In women with endometriomas, clinicians may use antibiotic prophylaxis at the time of oocyte retrieval, although the risk of ovarian abscess following follicle aspiration is low. Are medical therapies effective as an adjunct to treatment with assisted reproduction technology for endometriosis-associated infertility? Clinicians can prescribe a gonadotropin-releasing hormone agonist for a period of 3 to 6 months prior to treatment with assisted reproduction technology to improve clinical pregnancy rates in infertile women with endometriosis. Should surgery be performed prior to treatment with assisted reproduction technology or ART to improve reproductive outcomes? In women with endometrioma larger than 3 cm, the Guideline Development Group recommends clinicians only to consider cystectomy prior to assisted reproduction technology to improve endometriosis-associated pain or the accessibility of follicles. The Guideline Development Group recommends that clinicians counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of the ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. For infertile women with deep endometriosis, we found no evidence to recommend performing a surgical excision of deep nodular lesions prior to assisted reproduction technology to improve reproductive outcomes. Menopause in women with endometriosis. The Guideline Development Group recommends that in postmenopausal women after hysterectomy and with a history of endometriosis, clinicians should avoid unopposed estrogen treatment. However, the theoretical benefit of avoiding disease reactivation and malignant transformation of residual disease should be balanced against the increased systemic risks associated with combined estrogen and progestogen or tibolone. The Guideline Development Group recommends that clinicians continue to treat women with a history of endometriosis after surgical menopause with combined estrogen, progestogen, or tibolone at least up to the age of natural menopause. Asymptomatic endometriosis. The true prevalence of asymptomatic endometriosis is not known, but between 3 and 45% of women undergoing laparoscopic sterilization has been diagnosed with endometriosis. Is surgery beneficial for incidental finding of asymptomatic endometriosis at time of surgery? The Guideline Development Group recommends that clinicians should not routinely perform surgical excision and ablation for an incidental finding of asymptomatic endometriosis at the time of surgery, since the natural course of the disease is not clear. The Guideline Development Group recommends that clinicians fully inform and counsel women about any incidental finding of endometriosis. Primary prevention of endometriosis. Is there a role for primary prevention of endometriosis? We only found evidence on oral contraceptives and physical exercise for primary prevention, and their usefulness are uncertain. Endometriosis and cancer. What information could be provided to women with endometriosis regarding the development of cancer? The Guideline Development Group recommends that clinicians inform women with endometriosis requesting information on the risk of developing cancer that there is no evidence that endometriosis causes cancer. There is no increase in overall incidence of cancer in women with endometriosis. Some cancers, such as ovarian cancer and non-Hodgkin's lymphoma, are slightly more common in women with endometriosis. The Guideline Development Group recommends no change in the current overall management of endometriosis in relation to malignancies, since there are no clinical data on how to lower the slightly increased risk of ovarian cancer or non-Hodgkin's lymphoma in women with endometriosis.